Hey, I'm Zeb.
And I'm Maddie.
And welcome to the We Don't Know Yet podcast. Whilst both Maddie and I are healthcare practitioners, we understand that there's no one-size-fits-all approach to healthcare. Should you require any medical attention, please seek out your local healthcare practitioner.
Yes.
We got to know what you've been up to on leave.
Yeah, how long
It's
have you been for?
I have just been on, it's almost embarrassing, I think a 7-week break from full-time public hospital medicine, and it's the first time I had a break for around 5 years.
How is
Oh
that
my
embarrassing?
It's well deserved, it sounds like.
I was so burnt out. I had worked in eating disorders for the last 12 months and a lot of 24/7 on call for a week.
Yep.
And looking after really, really sick people that I would go home and worry about.
Yep.
And I thought, why not? So I've been living the professional athlete life, waking up in the morning, eating, training, napping, training, napping, eating, adding a dog walk here or there. So it's been great.
That
Big,
sounds
long dog walks or little dog walks for the little legs?
Just in the park, very small sausage dog. When I got my sausage dog, everyone said, why didn't you get a running dog, Izzy? And now I say, he's the perfect running dog because he's the perfect recovery dog.
Yes.
You just lie on the couch, cuddle. So, no, it's been a really good break, but I'm going back to work next week. So I think I'm ready now to use my brain and work with patients again.
Oh, it's so exciting. And are you jumping straight into full-time?
No, I'm making the transition to part-time private practice.
Mm-hmm.
I'm still, I've been in medicine and I've been a doctor for 10 years now, but I'm still saying, I'm still not exactly sure what I want to do when I grow up, which is, do I want to do a PhD and become a clinical researcher versus do I just want to work in private practice part-time and really enjoy my training and, things outside of work. And I don't need to have that answer, and I could maybe do lots of things because careers are long.
Yeah.
But just not wanting to commit to anything too much. And I want to work in private practice. I love clinical work. I love being able to spend more time with patients. And unfortunately, the public healthcare system can restrict your ability to practice how you want. So looking forward to doing more women's health, athletes' health, which are my real passions, and maybe actually doing a little bit of work with the Institute of Sport.
Amazing.
And trying to really build on that expertise and experience as the sports endocrinologist.
That's great. That's fantastic. Well, I feel like we need to give you an introduction. Welcome back to the We Don't Know Yet podcast. Before we dive in, we are so excited to be joined by Dr Izzy Smith. She is an endocrinologist with a special interest in sports and women's health. I feel like, Izzy, if it's okay, can you explain a little bit more about what you do? Because I feel like we're not going to be able to do it justice.
I'm an endocrinologist, which is a long word for hormone health.
Yes.
And often when we think of hormone health, we just think of reproductive hormones, but endocrinology looks after diabetes, so type 1, type 2 gestational diabetes. We also look after thyroid disorders, bone health, which is a real interest of mine with the female athletes, stress fractures, osteoporosis, reproductive hormones, fertility, adrenal conditions, pituitary. It's really broad. I chose endocrinology because I want to prevent complications. I want to prevent diseases, and endocrinology is supporting people who live with the condition rather than, treating the complication. I want to prevent the heart attacks from the poorly controlled diabetes or the kidney failure from the poorly controlled hypertension rather than, treat them when they've happened.
Yep.
And you get to work with athletes. So it was this eureka moment when I realized that's what I need to do. And I also have an interest in, as I said, female athletes. So I do a bit of work with FEMI, which is a women's health kind of running and tech company, and do a bit of work with Nike and the education side of things. So alongside the clinical work, which I really enjoy, I'm very passionate about education because a lot of people don't have a very good experience with the healthcare system, or they're just not educated on their condition. And I think we need to do a better job as the medical industry is educating the broader community as well.
Yep.
And that's why podcasts like we're doing today are so great, because you can, impact more than just the person in front of you.
We'd like to take a break from today's episode to give a quick shout out to our sponsors, Drip Digital. They manage all of our audio and video editing as well as our social media marketing. Without them, the We Don't Know Yet podcast wouldn't be possible. So thank you again.
Yeah, and I think that's why we were so excited to kind of get you on, because like we were talking about just off air before, still being so new to the industry, you kind of get a big shock when you walk in and just realize how low the education level actually is in general population. You kind of walk in thinking, oh yeah, like everyone will know about a lot of this stuff when we start talking to them about it.
Every single time I do a talk about women's health, my mind is blown. And it's like, how are we not taught this? And
Yeah.
you guys are younger than me, but I'm sure you've seen the movie Mean Girls.
Yes.
Oh yeah.
And there's the and I talk about this when I, do public speaking. There's the PE teacher who says, do not have sex. You will get chlamydia or pregnant and you will die. And that is satire. But, I'm 33. I did health around 20 years ago in PE. That's pretty much what we were taught. How to not get pregnant and not to get STIs. And that was the only thing we needed to know about women's health.
Yep.
And exactly. I think as you get more knowledge yourself, you think there's more assumed knowledge in the community, and there's just not.
Yeah, and I think it's almost like the opposite. It's like all of a sudden, even us coming out of the health uni degree space, we kind of come into the big bad world and go, oh my gosh, I didn't learn it all. I thought I learned it all.
The more you learn, you think you know nothing.
Yeah, that's
and
what
even
I
when I
mean.
go on podcasts, I'm like, I don't have a PhD. I shouldn't be discussing polycystic ovarian syndrome because I'm not Australia's best expert in polycystic ovarian syndrome, which is then an issue because people often with not much qualifications think they know everything. And that's why we're in this confusing place of who do we even trust for information?
Yes. The loudest voices are often the most unhelpful.
A lot of the time.
Yes. Yeah, absolutely. And so obviously endocrinology really laid on the foundation of hormone health, it sounds. Let's strip it back way back to just, I guess, what is a hormone? How would you define a hormone? Because again, I think that's something that we often assume people know. And look, to be honest, if someone asked me to explain what a hormone was, I don't think I'd do a very good job at it.
Yeah. Great question. So a hormone is a chemical messenger that travels from one part of the body to another part of the body via the bloodstream. So that's what makes a hormone a hormone. We have thyroid hormone. Thyroid sits in our neck. It creates thyroid hormones, which, little molecular, chemical structure, and then travels through the body and acts on almost every cell. It acts by acting on a receptor. So on our cells, we have receptors, which is a bit like a lock, and the hormone comes like a key, opens the lock, and then creates a series of second messengers. So, for example, thyroid hormones impact our metabolism. So they increase our metabolic rate, our heart rate, our digestive system. And that's why if someone has too much thyroid hormones, they're often anxious, shaky, lose weight. And, we have more than 50 different hormones. So there is our thyroid hormones and obviously our reproductive hormones. We have our adrenal hormones. Everyone hears a lot about cortisol. And there's also hormones that control our salt and electrolyte balance, what's called mineralocorticoids or aldosterone. We have our kind of pituitary hormones, which are the ones in the brain that create growth hormone, prolactin, and control some of our other hormone organs. But really simply, just know hormones are chemical messengers that travel through the blood and act on another organ to have a series of secondary effects.
Amazing. Thank you for
that.
that.
And to really go back to that point of, biochemistry is in discussion a lot these days. It's not as easy as just like trying to drive up one hormone response or drive down one hormone response. They all interact and interplay with each other.
What I love about endocrinology. It's this, we call positive and negative feedback loops. And it's almost a detective game of finding where in the system is the problem. Is it at the pituitary? Is it at the organ? Is it at the cells that they have abnormal receptors? So the hormones aren't actually working on the hormones are normal, but the cells aren't responding to those hormones, So as you said, it's much more complicated than just, in inverted commas, balancing hormones, very big complex system and why it takes quite a long time to, become an endocrinologist.
Yeah, and look, on that note, there's obviously so much to learn in that space. What made you, what gave you an interest in the endocrinology space? What made you want to get into this rather?
Yeah, so I had an interesting medical pathway. First, I was never that amazingly academic at school. I went to public co-ed schools in Tassie where the boys were like letting off stink bombs in maths. We had 3 different science teachers in grade 8 because the class was so naughty and the teacher said like, we just cannot teach in this environment. And I was actually talking with a friend about this yesterday. It was just a couple of random lucky things that led me to get a good enough school into medicine. I met a random guy at a party in grade 10 from another school and we ended up going out and he was really into school. And I can remember when I said I wasn't going to do pre-tertiary maths, he was like, why don't you just drop out of school now? I was like, okay, better do pre-tertiary maths then. And then I had this amazing science teacher in grade 11 who really taught me to believe in myself and gave me confidence. And I'm somehow got a good enough enter score, which my entire family was shocked by. They're like, you're not smart, you're just really good at sport. So I got into medicine, did it, thought I wanted to be a blood cancer specialist, got really depressed. It was far too sad. My own dad actually passed away from a blood cancer. I realised that wasn't right for me. And I thought about being a lung specialist. I thought about being a kidney specialist, but it came back to that thing. You were treating the disease once it already happened. Yeah. I really wanted to focus on more preventative health. I also saw how much misinformation there was about hormone health, and that was exciting to me to play a role in community education and also getting to work with athletes and young people. I like working with young people because you have the opportunity to have such a positive influence on the rest of their life. And it goes back to that prevention. And also a lot of endocrinology is education, and the doctor-patient relationship is incredibly important. And also looking at something like type 1 diabetes. You can't treat someone with type 1 diabetes without also addressing their mental health and, you know, all the other things going on in their life. So that really holistic practice being integral to good patient outcomes was what also drew me to it.
Amazing. Yeah, that's
I
really
love
great.
that, and I feel like the whole healthcare kind of bracket at this stage, whether you're in allied health or working in medicine, is starting to really switch onto that holistic approach. You know, a lot of the research coming out about like biopsychosocial models and a lot of those processes these days, instead of just looking at structure and treating structure and function.
Exactly. And I don't know if either of you have ever had a health condition or had family members, but everyone has been to the doctor where you go in, they talk to you in mumbo jumbo for 10 minutes. You have no idea really what is going on. You're not reassured, and you're told to come back in 6 months, and that's it.
Yeah.
And you leave feeling completely, overwhelmed, disappointed. I actually got an autoimmune kidney condition when I was 18 called glomerulonephritis, and I had some really crappy experiences with the healthcare system and some really good ones. And it was that biopsychosocial, that they knew about my family, my sport, that even though I had kidney disease, they were going to support me to continue running. Because that was really important to my mental health, and it's that whole bigger picture. So I always say that anyone who works in healthcare almost needs to have a family. I don't wish poor health upon anyone, but almost needs to have some kind of mini scare every now and then, just to have that empathy of what it's like to be the patient and how overwhelming and difficult navigating an illness and the healthcare system can be.
Yeah, and just before we dive in, like, have you found that the mindset has shifted slightly recently in terms of the fact that, like, it's not necessarily, we need to do obviously a lot better still in healthcare. I think we were talking to Chapo recently, who you also know.
Yes, we're running.
But we were talking to him about the fact that the healthcare system's a really slow-moving beast. Yeah. Like, it's going to take a lot of time to get some of the change in that we all would
bureaucratic
like to see.
And 20 years behind. Yeah. And even we know research takes like 15 years to actually be implemented. Yeah. How can it be that slow?
Yeah. I mean, and then once you get to that 15 years down the road, it's all changed again anyway,
Yeah. There's a lot of issues with the healthcare system, and often, doctors are slammed, which always makes me upset. But again, I'm sure there are, times when doctors really are just right little tossers to people. And in any industry, there are people that probably shouldn't be in that industry.
Yeah.
I do think the healthcare system is changing. I think the younger generation of doctors, but we are fighting a system that doesn't support us in the public to give that really good holistic care. Yeah. And that's why often I think people very understandably are drawn to seeing, some naturopaths are great, but some, I would say, do practice outside of their scope. But of course you're going to want to see someone who sits with you for an hour, validates your experience, displays a lot of empathy, rather than that 10-minute appointment that you leave feeling shit.
Yeah.
And the medical system needs to step up, and I'm hoping that next generation of doctors and maybe changes within the healthcare system, and as we care more about our health in general as a population, allows that to happen.
Yeah, and I was just going to say, I feel like, have you found that side of it's been driven really hard as well, in a sense that I think, we get people that come in, see us in the allied health space that are just asking questions and they're curious. And people these days, I mean, we were talking about the fact that, social media has such a big influence. It's a really big market for there's a lot of legitimacy and a lot of misinformation. Yeah. There's two sides of the spectrum there. But the good thing to come out of all of it is that it seems like people are really switched on to the fact that there is a problem that we're trying to work through.
And often patients say to me, I did some Googling. I know I shouldn't have. I'm like, no, I want you to do some Googling. Come with questions. Have them written down. The more informed and involved, and this is evidence-based, we know when patients are more involved in their healthcare, they get better outcomes. So even though I begrudge social media and some of the misinformation that, add butter to your coffee if you want to lose weight and, eat an all-meat diet, or dairy leaches calcium from your bones. There's endless rubbish. I think the net impact, is a good thing because of that more patient engagement. And also, I think patients expecting more from the healthcare system, which is good. None of this old school paternalistic, listen to me, do this, no questions at the door.
Yeah, and like you definitely see that in the older generations. Like I feel my grandparents, just with their old age, have had a few health conditions pop up and they're like, oh, I'm doing this. I'm like, why? Yeah. Oh, my doctor just told me to. I'm like, do you know why
the nice man said to me, and I'm like, I'm the young doctor and I'm saying no, but the nice man said.
Yeah, oh, it's insane. And I can imagine that's
generational change.
Oh, for sure. And it's probably like what I'm imagining is led you into wanting to do more of the outpatient private practice stuff because you do have more of that closer relationship with your clients and can spark that, holistic change.
Fingers crossed, that's what we hope for.
Touch wood. Amazing. So you did briefly mention, I guess, some of the key players in the hormonal world, I guess you can call it. When it does come to the endocrine system, like what are some basics that we need to know? So you did mention the thyroid earlier. Are there any others that we might need to, I guess, introduce?
It's a very broad question. For women, the common things are thyroid conditions are very common. Reproductive hormone issues like polycystic ovarian syndrome, functional hypothalamic amenorrhea. So if you're not getting your period, then bone health is incredibly important, and that fits into hormone health. But really, most behavior changes and lifestyle things are good for all of our hormone health, and that's generally good for most parts of our diet, most parts of our health, which is, a varied diet with lots of micronutrients. We know our thyroid needs, selenium, iron, zinc, magnesium, and that's, good because it comes from lots of fruits and veggies, and that's good for our health generally. Then another big part of endocrinology is our metabolic health. So insulin resistance, I look after, conditions of lipids, so high cholesterol, triglycerides, metabolic syndrome, and that's a big area as well. We do know that obesity is causing a lot of disease, and we've seen, I think, very positive changes made regarding focusing on lifestyle behaviors rather than a number on the scales, and a focus on health-related behaviors rather than weight being the only, determinant of our health.
Yeah.
And I also think we can't take that to the point that we don't acknowledge that carrying extra weight can increase the risk of a lot of conditions like certain cancers, osteoarthritis, and that some, and that people do just still deserve medical support with weight management. That's not, someone wanting to go from a 12 to a 10 and getting Ozempic from an online. Go to Ozempic, that's a whole other kettle of fish.
Should be a whole other episode.
I know. But, I do, we do know that obesity is a big, global health issue, as is inactivity. So that's also something we look after. So it's a very broad specialty, as you can see.
And a lot of misconceptions, I can imagine, as well within that.
We're talking offline about cortisol and or polycystic ovarian syndrome. That's a big one. And people are desperate just for information. It is confusing at the moment because you're told so many different things.
Yeah,
and if you've ever had a health condition yourself, that's just a nightmare to navigate.
Oh, for sure. I've definitely had a fair few, or more recently as well, clients with PCOS come through the doors and like, my doctor told me to cut out carbs and start fasting. I'm like, no, please, just respectfully do not listen to them.
And I will just say this, doctors are not the people to go to for nutrition advice.
Yeah.
They're not trained. Generally, they will just give advice based on their own personal experience.
Yeah.
I was actually thinking about doing sports medicine as a specialty halfway through physician training. And I remember being at this conference and 3 middle-aged men got up and told a room full of sports medicine doctors that, You don't need carbs. Athletes should only have 20% of their diet as carbohydrates. High saturated fat doesn't cause heart disease. How to get around those silly dietitians that don't know what they're talking about. And if the cardiologist doesn't want to take the patient off their statin, tell them to see a new cardiologist. And this was the head of sports medicine. I was livid sitting in, and I'd just done my physician training.
Oh my goodness.
And this is 3 doctors in sports medicine. I just could not believe it.
Yeah.
And I think doctors can have a bit of a God complex and think they know more than anyone about everything. And they're just not experts in nutrition. They haven't done, they haven't been trained how to interpret nutrition studies. And people sometimes ask me advice on, what should I be eating for this amount of training? I go, I don't know. I'm not a sports dietitian.
Yeah.
See an expert.
Yeah.
I don't know how I got onto that topic, but yes, doctors are not the right people to go and do for a nutrition advice, and they generally will just give their own advice.
Yeah, that's crazy. Even like if you said, as you said, like the head of sports medicine, like one person with that credential, fair enough, they're going to have some credibility or have that authoritarian
This particular person has written books now.
Yeah.
And they're just not an expert in nutrition. And that's just something to talk about actually. If there's someone giving advice on a specialty that they haven't been trained or work in, you think, why are they doing that?
Exactly.
Because wouldn't they just leave it to the dietitians or the cardiologists, unless they're giving wildly different advice than the cardiologists and the dietitians? And you think, well, why are they giving wildly different advice? I've never seen a cardiologist that tells people to have a high saturated fat, low carb diet.
Yeah.
And they're the people that are actually looking after people with, coronary artery disease.
Yeah.
So, you wouldn't get advice by a mechanic on a healthy diet. Yeah. So don't follow the psychiatrist's advice on, heart disease, and don't follow the heart disease doctor's advice on, vaccines for your baby, because they don't practice in that. I think and unfortunately, I don't think there's enough discussion regarding how much doctors specialise. Yeah. And just having been a doctor doesn't make you an expert. You did a medical degree, it's a basic science degree with a little bit of clinical stuff. If you haven't practiced in 20 years, you are not qualified to be giving advice. So yes, be warned of some really wacky doctors on social media. I know I just went off topic, but
I think it's really good to bring it back to the fact that, and like this is a big driver for why we get so many different guests on
this is why we do this whole podcast. Yeah.
Like there's been such a big emphasis, and I mean we only see it from the allied health perspective, but even in the hospital system, big emphasis on multidisciplinary care. Even when you're in hospital, you're being managed by so many different treating physicians and different specialties, and you have allied health working in the hospital with doctors and working hand in hand for that reason.
Everyone's got their own piece of the pie.
It's very concerning if one person's trying to be an expert in 5 different topics,
because there is way too much information to cover in one topic, let alone 5.
Exactly.
Well, even what we were saying offline, like the knowledge that you do know is a drop in the ocean. Like the more you know, the more that you learn, the more you realize how much you don't know.
Exactly. So
wild.
Maybe let's again strip it back a little bit. Like people look at their lifespan and kind of don't really understand what's normal or what should be happening as they kind of progress through that lifespan. Did you want to talk to us a little bit about what we expect to see kind of through the
hormonal changes?
Yeah.
So again, hard to give advice for everyone, but I'll talk a bit about women and men, maybe reproductive hormones, because they're the main ones that kind of can change. So we know, puberty starts at around, 10 years old. The adrenal glands start waking up and making hormones first. So the adrenal glands actually make some reproductive hormones. And then, puberty then starts to begin. Breast budding happens, and then girls should get their periods within around 18 to 24 months from that initial kind of breast budding. And I work with young athletes, so if there's a 15-year-old that hasn't had her period yet, but she started developing, kind of mild breast budding at around 12 years old, I know that she's overtraining and that her period's not happened because of that, too much exercise. Then often in the first few years for women, periods can be a bit irregular because they're not ovulating, so what we call an anovulatory cycle. It's often really heavy periods, and girls are often put on the pill at that time, which is quite, controversial. Are we just masking the symptoms? There are other things we can do for really heavy periods in that adolescent time. You can have some, progesterone at the second part of the cycle. Even just knowing that this won't be forever. But we can't expect, 14, 15-year-olds to be going to school if they're having, terrible flooding through their school dresses and just be told, live with it but never go on the pill because that's the worst thing you could ever do. But that generally does get better within a few years. Then for women, their cycles should be regular, and as they make more estrogen, their bone density doubles from, adolescence to adulthood. So that's why having our reproductive hormones, so a regular menstrual period, especially in adolescence and early 20s, is critical for bone health. We know it has a much more negative impact on your bone health if you have 5 years without periods in your teens or 20s than in your 30s or 40s. So focusing, I'm all about bone health. Osteoporosis is a terrible condition. We know fractures increase risk of mortality. Even other conditions we see are increased. So we want to do everything we can in our youth to, focus on good bone health. Then we reach our peak bone density in our 30s. Fertility is a really interesting one, and I always go on about, and it makes me feel like I'm kind of being a bit, not anti-feminist, but no one wants to be told that their fertility is decreasing because it's not very empowering. But we are seeing a lot of people having to go through IVF because they weren't told that, their fertility will decrease after the age of 35. I'm 33. I don't have children. I froze my eggs, when I was 32 because I know egg quality does decrease after 30. Yeah. And if you're not wanting to have children until your late 30s or early 40s, knowing that you might have problems or doing things to protect your fertility like egg freezing are important. I must admit, the fertility gods, they were pretty hard on women. Bloody men can keep having kids, or there are complications, risk increase, but it is really unfair. But not being informed about this is not empowering.
Absolutely. Yeah.
Having all the knowledge is important.
Exactly. It's not empowering to be told, your role as a woman is just to have children and, you should be having babies now.
Your biological clock is ticking.
Yeah, that's not great. But not having that information is also not empowering, but being told in a much more positive way.
It's informed consent, right?
Yeah, exactly. And then for women, perimenopause, so often can start, 5 to 8 years before menopause. For some women, it can be earlier. So we say premature ovarian insufficiency, POI. It used to be called premature ovarian failure, which is really horrible.
Yeah.
It's a bit, there's a lot of kind of shitty medical terminology. Like a hysterectomy was called a hysterectomy because it was thought the uterus must be the cause of a woman's hysteria. Women
I did
with
not know that at all.
Yeah, women with mental illness used to have their uterus taken out as a treatment because it was thought that it must be the uterus, and that's where the word hysterectomy comes from. So just a little bit of medical gaslighting.
What's the patriarchy in the medical industry, I'm feeling?
Exactly. So, and we've changed premature ovarian failure to insufficiency. But then menopause, we say, is normal, from 45. But women can have, start to have symptoms of perimenopause, in their early mid-40s is very common. And perimenopause can be horrible. We know that there's an increased risk of mental illness and suicide at this point.
Yeah.
And I often discuss when I do talks that we do have this culture of women just being expected to endure. They endure difficult periods. They endure pregnancy and having to go to work and not tell anyone even though they feel terrible. They endure childbirth and then they're shamed if they have an epidural or pain relief. Then they're meant to endure perimenopause and carry on like they're not, having really significant symptoms. And, and then they have babies and they go to work all this time. So I really talk about, perimenopause and all of these other things because women need to stop suffering in silence. We need to know it's okay to talk about how we are feeling and the experiences we're feeling because most likely someone else is feeling them as well. Yep. And we need to talk about them to take away the shame so we are more supported in, a workplace environment, family environment, all of those things.
Yep.
So I'm really going on in this answer.
No, it's
and then
great.
We say menopause is 1 year after the last period. Then other ways through the life, there's this myth that testosterone gets lower with age, and that's actually not the case. Men's testosterone doesn't decrease with age, but we do know testosterone decreases with poor health, low physical activity, increasing obesity, especially metabolic syndrome, so central obesity, but testosterone shouldn't decrease. So these dodgy youth clinics putting all men on testosterone to combat natural lowering testosterone with age is, not good. And just about testosterone, actually, just an FYI, essentially testosterone is anabolic steroids. So people who are on steroids are on testosterone. That will generally make men infertile. Yeah. So, it's a bit like the pill. the good thing with the pill, if you stop it, your periods come back in a month.
Yep.
For men, it's often 12 to 18 months
Wow.
that fertility takes to recover, and some people it doesn't at all. So a lot of people are on anabolic steroids. Like, they've done studies, and actually it's really common, which is kind of scary.
Very
It
scary.
is a little bit, and it's just something again that I think, you know, because of all the misinformation out there, it's like everyone on the anabolic steroids doesn't actually know what their long-term prospect looks like. They know what the short-term looks like, but long-term wise and health-wise, they're probably not really being run through all the risks of actually taking
And
something.
I guess it's hard as a doctor because you might have someone with anabolic steroids who says, can you look after me? And you say, well, I can, but having you on these, I'm almost condoning it. But we still have a responsibility to monitor the hemoglobin, because they can become the hematocrit, so the thickness of the blood can get too high, it could increase the risk of strokes. They can get liver problems and also psychiatric problems. Quite a few interesting case reports of people doing crazy shit. Roid rage, it's a real thing. And the legislation is a bit weird because, you know, if someone was on drugs and did something terrible, you'd say, well, you took those drugs, you knew that you were
Under the influence. Yeah.
and something like, you know, anabolic steroids. So I know I'm at the age where I go to a lot of hens parties, and the strippers always have back knee, and I'm like, oh, they're on these steroids, aren't they? I wonder if I should tell them, do you really know what's going on?
Do you know what happened?
You whip out the textbook midway through, you're like, hang on a second.
Yes. Do you need me to examine your testicles? They're probably pretty small. But
Not in the way that you're used to.
So that's, you know, our hormones, you know, do vary throughout our pregnancy. Is fascinating. Like, I'm a doctor and I work with fertility, and I still am just like, holy shit, we have two cells put together and it makes a baby.
Yeah.
That is incredible. And I could go on about hormone health, you know, thyroid health before pregnancy, thyroid health, you know, it's too complex to get into a broad topic, but, you know, thyroid and miscarriage, bone health in pregnancy is a really important one. I've lost count of how many patients I've had who have had stress fractures when they're breastfeeding because you don't have your periods back, so your estrogen's low. Your baby is sucking all the calcium out of your bones to create its own skeleton.
Yep.
And you're increasing your load quite rapidly after being pregnant. So that's a really high risk period, and no one is told. You know, no one's told to supplement with calcium. No one's told to, you know, really kind of gradually increase your load. They're told about their pelvic floor, but not really about their bone health. So yeah, hard to give advice that covers everyone. But there are, you know, different periods of our life. You know, we will have different hormonal needs, but the basics are always there. Get enough sleep, eat well, eat enough carbs.
Carbs are life.
Yes. Carbohydrates are really important for hormonal health, actually. I do have concerns about low carb diets, especially for women and young women. We do know a low carbohydrate diet increases the risk of functional hypothalamic amenorrhea, i.e. losing your periods from, you know, underfueling, overtraining. And also important for cortisol. We know for patients with anorexia, they have worse bones than someone who just has low estrogen from a medical condition like Turner's, where their ovaries don't make hormones. And it's thought the higher cortisol is part of that.
Okay.
If we have a low-carb diet, our cortisol goes higher to try and increase our blood glucose levels. Maybe we should just talk about cortisol. Maybe I'll go back. We can talk about cortisol. That's a whole other topic.
Yeah, absolutely. Yeah, I read somewhere when I was doing my upskilling, I suppose, in the ED space, individual living with anorexia for about 12 months has a 60% increase of osteoporosis. Yeah. Which is wild. Like, that's a massive jump. I don't know if that's factual.
I'm not sure. Osteoporosis, it's based on these kind of T-score criteria in our bone density. If you did have an eating disorder for a period of time later on, you're definitely going to have increased risk of osteoporosis. It also is where your bone density is at baseline. A lot of bone density is genetic. So if your bone density genetically was quite good, you developed anorexia, maybe your bones would decrease, but they wouldn't be in the osteoporotic stage. The good news is generally our bones bounce back. So if you improve your nutrition, you get your hormones, estrogen back from having a period. Just FYI, the only way to have estrogen naturally is if you're ovulating and, you know, your menstrual cycles are working. So if you don't have a period, you're not making estrogen. And estrogen is so important for we think of reproductive hormones as just, you know, well, I don't want to have a baby, so it doesn't matter. Estrogen is important for our blood vessels. So we know low estrogen increases the risk of heart disease. Estrogen is important for our cognitive and executive, you know, functioning. We know people that have low estrogen, you know, don't have estrogen in their youth have increased risk of dementia later on. So estrogen is a whole body hormone. So I'm really want to drill that point.
Yeah.
You've lost your period. That is not normal, even if you're an athlete. Reproductive hormones are important for all of our health, not just for having a baby.
Yeah, and a lot of the time it is focused on babies, and young women often aren't really, that's not on the cards for them. So they're like, oh, well, it doesn't really matter.
Well, it goes back to the PE teacher. All that matters is not getting chlamydia and having pregnant and dying. They are the only things to worry about women's health.
Yeah.
But yeah, eating disorders and bone health, a really big issue. Vertebral fractures, can have chronic pain, disability, but we can improve it by improving nutrition. And I see a lot of people, again, who want me to magically fix their bones, and I say, I can give you a little bit of estrogen, maybe we can give you some meds, but the number one treatment is improving the nutrition, and that's why so much of health is just the basics. Get the low-hanging fruit right. The wanky biohacking that you'll read on the, Peter Attia podcast, that's if you're really going for the, the top stuff, but get the basics right before we worry about all the others.
And that's what I always say to clients anyway, like, good health isn't sexy. It's the basics. It's the boring shit that you probably heard a million times over, but it's the crux of it.
So it's the stuff no one wants to click on TikTok.
It doesn't get, I was going to say, it doesn't get many Instagram shares. It's not like this controversial new fact.
Absolutely. I do actually have a myth that I want to clear up with you, if that's okay, because I've seen it on
I love myth busting so much.
And look, I think a lot of people have heard of it. Like, I saw it on TikTok and I didn't really say anything, and a few of my friends have brought it up in conversation. But it's this particular TikTok, and there's probably been a few of them, that go into, obviously, a female hormonal cycle spans across around 28 days if they're reproducing or
regular
ovulating.
cycle,
Yep. But apparently a man's one only spans across 24 hours. I don't know how factual that is. I'd love to get your expert opinion.
Okay, this is just...
I thought as much.
We should make this a new segment on the show.
Well, it's just it's like comparing apples and oranges.
Yeah.
So testosterone for men increases in the morning, and that's why we get you to test testosterone in the morning. And then we'll lower at night. So it's not really a reproductive cycle because like women's reproductive cycle is related to ovulation.
Yeah.
And the hormones do differ. Start of the cycle, you've only got estrogen. After you ovulate, you've got estrogen and progesterone. It's more just men's testosterone higher in the morning.
It's very different. Yeah. Because this particular video was like, that's why men can fall asleep so much easier at night and women often have difficulty. I was like, this is very,
I don't think I'd compare it men versus women. I'd just look at women's hormones as something, it's not incorrect, but it's just a weird comparison.
Yeah.
But some people can find that... Well, it's interesting. Progesterone in the second part of your cycle can actually make you sleepy. And that's why if someone's taking progesterone tablets, you tell them to take them at night. The other thing is you can't generalize for everyone. Probably most people's sleep is not because of their reproductive hormones. It's because they're scrolling on their phone at TikToks that are probably
It's watching
scaring
that
them
video
about
that's
their
keeping
health.
them up at night
Exactly.
time.
me wondering why I'm tired. No, but I definitely find in my luteal phase that I am just like a zombie, no matter how much sleep I get.
It's so luteal phase is after you've ovulated until your period, and that's when we get PMS. PMS most likely related to abnormal response to metabolites of progesterone and, individual. But, tired. I'm a runner. Sometimes when I'm running in that late luteal phase, I'm like, I'm not hurting. I'm not out of breath. I just want to lie on the side of Centennial Park and have a nap.
Yeah, absolutely. And like we that's how we met through a run club with Chapo as well, USC.
Is that the crazy one that's at 4:30 in the morning?
Absolutely.
Oh my God.
It is
Crazy.
great. We admittedly, since we've both been quite busy in our respective practices, we have dropped off quite a bit.
I was going to say, from a hormonal perspective, probably not the best time of the day to train.
No,
Cortisol's low.
Yeah.
Still a bit asleep.
Oh,
but
absolutely. But there are definitely some times
But there's
around
good
that
vibes.
stage.
There's great vibes.
I do 440. I met Chapo's a bit of a celebrity on this episode. I met Chapo at the 4:40, which starts at 5 a.m, so I can't really talk.
Oh, does it start at 5?
Yeah,
That's good.
yeah.
See, that's a bit more generous.
Not the middle of the night.
No. Well, there's definitely times around that stage of the cycle where I will try and run. I'm like, I'm just going to tap out. I'm just going to sit on the curb.
I always say to people, listen to your body, decrease intensity. And there's a lot of controversy at the moment about should we periodize our training to our menstrual cycle? Should we train harder in the follicular versus luteal? Which I generally do. But it's about listening to your body.
Yeah, it's so
and
individualized.
that's what we have really, I think, with so much information and data, we've kind of forgotten what a, excellent, model that is of just listening to our body. And you look at, you talk to Shona Hallison, who's like the expert on recovery. She says you can get all the data, all the metrics, Whoop, Aura, Garmin, none of them have actually been shown to be that much better at all if, they're the same as athletes who listen to their body properly. We'll get back to myths. Should we talk about cortisol now? So cortisol is made from our adrenal glands, and it is a life-critical hormone. So if we didn't have it, we would die. Its function is to keep our blood sugar normal and our blood pressure normal. So if someone comes into hospital with low blood pressure, low blood sugar, we always check cortisol. It's been given this really bad rap through oversimplification that cortisol causes insulin resistance, and too much cortisol can have a negative impact on our immune system and on our bone health, which it does. If you have pathological conditions where you make too much cortisol, like Cushing's, you get osteoporotic, you get central obesity, unwell, it's bad. But then we've used that information to say anything that increases our cortisol naturally as a functional adaptive response, which, the cortisol is helping our body, i.e. go for a run, that is therefore bad. So cortisol, when we exercise, will increase because it's helping us increase our blood glucose level so we can use it as fuel so that we can increase our blood pressure so we can pump blood through to our, our muscles and exercise better. It's part of our stress response. It's a functional adaptive response, which is critical for life. So cortisol is doing its job. And then there's been this oversimplification that cortisol too much has these negative effects. So therefore high intensity exercise is bad, which is like insanity. We have so much data showing high, moderate to vigorous intensity exercise improves diabetes, improves insulin resistance, improves polycystic ovarian syndrome. I've had athletes who purposely don't do any, not athletes, patients, don't do any high intensity exercise because they've got PCOS and they're worried that worsens their PCOS. And it's like you want to bang your head against the wall because from that basic, mechanisms would mean people with type 2 diabetes or insulin resistance and obesity shouldn't do exercise because it's cortisol. Like, it's ridiculous. Our cortisol will decrease after we exercise. We need to, we recover, eat enough food, get some rest. And cortisol goes back down. It's a bit like noradrenaline. It's an adaptive response which is appropriate. We do hear about, things to lower our cortisol, which is good. And if we are busy and stressed all the time due to the behaviors, there's nothing wrong with your adrenal glands. It's because your
lifestyle.
Yeah, your lifestyle.
I feel like this is where a lot of this conversation starts from. It's like put stress and cortisol in the same sentence and it's all of a sudden like the whole world, the wellness space just implodes on itself and just gets so excited. And
people are, and the other thing I found interesting, like I was kind of reading this Instagram post of a triathlete who said, after Kona Worlds, I got adrenal fatigue because my cortisol had been too high. Adrenal fatigue is not a condition. It doesn't exist. You're just fucking exhausted. Yeah. You don't need to pathologize. Like, we've got to this point now that we have to pathologize
to feel better.
Yeah. Like, I had adrenal fatigue, therefore I need to have a rest from training for a few weeks. No, you're just exhausted and burnt out.
Yeah.
And we don't need a false medical condition to justify that our bodies need rest. We're hunter-gatherer cavemen. We used to, only be up for maybe 4 or 5 hours a day and then rest in our caves the rest of the time.
Yeah.
And we've changed our lifestyles rapidly and then expect that we're not going to get exhausted and burnt out. So there's nothing wrong with your adrenal glands. Your cortisol production is appropriate. It's your behavior, that is the issue. So don't go test your cortisol. It fluctuates up and down all the time. Having it tested doesn't give you any information. I would never check someone's cortisol just randomly. If they had signs and symptoms of too much or too little, I would do special, it's hard to explain, but called dynamic testing to see if there actually is a problem with the system. We're not just measuring the level.
Yep.
And again, all of these discussions regarding, my cortisol was too high and that led to this, this, and this, it's purely based on mechanisms. We don't have evidence in people that don't have diseases of cortisol production that, lowering your cortisol from doing all these things on TikTok actually, improve our health.
Yeah.
I do think, not resting, not recovering will increase cortisol and will have a negative impact on recovery, but it's one very, very, very small piece of a much bigger puzzle of the issues of not prioritizing rest, not prioritizing proper nutrition, recovery. So cortisol is just, like we said before, it's become the new popular thing. A few years ago it was leaky gut. I don't know what other, hormone balancing. It's just like this kind of, oversimplified mechanism-based, pop thing that gets lots of shares on TikTok.
Yeah.
And people like to feel there's something wrong with them.
Yeah. Like, oh, that must be me. That's why I'm so tired. I'm like, well, no, you're just sleeping 4 hours a night.
Yeah. And I think we like to feel that, and I see this with patients all the time. They want a really complex solution for why they, maybe they can't lose weight, or maybe they feel tired, rather than the low-hanging fruit. And I'm not judging someone for that. Busy lives are hard. Look, weight maintenance is really hard, but we don't need to create these overly complicated, conditions that don't really exist to justify needing to sleep, needing to eat well, exercise regularly.
We bypass the basics and often go to the more complex, trendy things that sell.
And to be honest, like in today's day and age, it's almost like you need it's more of managing your cognitive load and actually like your behavioral load versus actually anything to do with the body at all. It's like we live in a fast-paced world where we're go the whole day. We come home, we sit on our phones at night time till like 11 p.m., wake up at 5 a.m. and go again,
Yeah, and you're, as an osteo, you would see that, our stress hormones from psychological stress will impact our muscles because, our muscles can't really tell the difference between the stress hormones from psychological versus physical stress. And that's why I say to athletes, if you're psychologically stressed, your bodies or your muscles are already up here in terms of their load. So you can't add, another really big high intensity session because you just can't deal with that much load. Yeah. And the psychological stuff, completely.
And it's huge. I mean, you see like there's so many different types of patients that come in through the door, but you just see that it's like body wise, they're actually like just fatigued and then they're just doing all of this extra stuff within their day that's just adding to that. It's just crazy.
It's always a classic case of getting tension around here as well. Like I know whenever I get a massage, they're always like, oh, you're stressed. I'm like, isn't that funny?
It's so validating, isn't it? When they're like, oh, you're so tired.
Oh, yes, I am.
Yes, I am.
That's why I'm here.
Tell me that I need to look after myself better.
It's
really funny. And it does show. We like to think there's a problem. We like to have that, validation of you have something wrong with you. Whether it's you probably knew you were stressed and tired and needed rest. But it's very nice for someone to tell you, yes, you do.
It's like an excuse to rest almost because our world is so like hustle, which I have so many issues with. And
I've been trialing a new approach recently with some of my patients and like getting them in, sitting them down, letting them talk to me about what they think is going on, and then getting them to write down what it is that they do every day for like a week, and just like sit down and actually look at their behaviors for the week, and start to unpack some of that. Yeah, like they look at it and go, wow, like like I don't have any time to do any exercise. I don't have any, and you sit there with them and you look at this, essentially like a weekly calendar that you get them to prepare, and they kind of go.
Tell them to put the screen time app on their phone.
Oh gosh, yeah, that's stressful for anyone.
That's my shame feeling. It's like, oh god.
Yeah, 9:00 on a Monday, I always get the notification. It's like your screen time was increased by 40%. I'm like, don't do
god.
that.
As an FYI, just as a little public service announcement, I got this app called Opal, and it blocks all social media unless you go in and unblock it. And then it also tells you your screen time. It's really good. Changed my life, I would say.
I might have to get that because admittedly I do scroll late at night.
You go in the lift and you're like, at work, why have I opened Instagram? I'm in the lift for 2 minutes.
Yeah.
Just keep your freaking phone in your pocket, Isabel.
Yeah.
I always call myself Isabel if I'm in trouble. Normally it's Izzy, but if I'm annoying myself, I'm like, Isabel, what are you doing?
Word. All right, should we jump into our segment?
Yeah, I reckon we get into our new segment, which we started last week, which Maddie threw a curveball at me last week.
I did. Izzy, I feel like you're going to nail this.
Yeah, I feel like you're going to be
Don't put the pressure on me. Remember I said doctors, not experts in everything.
Yeah,
unless it's a hormonal condition.
Well, Maddie went really obscure last week.
I did.
And
you
I felt
back?
stumped, so I'm getting her back. But you're involved in this as well.
Yeah, pressure.
The good thing about today, though, is that we decided that we're going to include clues in this. So there's going to be a clue for
We're
each of them.
kinda now.
Okay, the first condition that we're going to go through that I'm going to get you guys to guess is called Alice in Wonderland syndrome.
Oh.
I feel like I have actually heard of this. But that's all I can say. Alice in Wonderland. Is it when you think that you're really small compared to everyone else in the world?
That's pretty good.
I'm going to flip it and say...
I didn't even give the clue yet.
Sorry,
That's awesome.
I think I have heard of it before.
Yeah.
Is that right?
Yeah, so it's a neurological condition.
Oh, you have a limb that's really part of your body is really small?
No, so neurological condition, like a psychological condition. It distorts your perceptions of visual and spatial perception, essentially. So, like you see shapes differently, or you like look at yourself and you see a different size to like the size that you are. And
is this just an LSD trip? Wasn't he on LSD? The writer when he made Alice in Wonderland.
Yeah, I feel like the name kind of.
The smiling cat.
Yeah, the smiling cat. Yeah, that's all my clue was the environment in the Alice in Wonderland movie.
I feel like Alice in Wonderland syndrome
it's got another name for it, but I forgot to write it down, so I'm not going to the actual medical condition.
I love that. That's great.
Yeah. Okay. Well, that was pretty good.
Wow,
I really need to do some work. I think. Like,
sorry,
really bad.
Like when I was a little kid, like being the first to hit the pinata and then it like breaking, and being like, oh crap!
What have I done? No one else got to hit the pinata.
I'm sorry.
Damn, this strength.
The next one is xerostomia.
Oh.
Yeah. It's a
Zero is in XERO.
XERO, and I'm going to give you the clue because I feel like this one's a little bit more like medical. It'll be commonly seen by dentists.
Because that's mouth, like zero.
So stomia, mouth, zero. Can you give another clue?
It has to do with the environment of the mouth.
Is that like, I don't know, infected gums? But that's just like gingivitis.
What about no gums?
No, that would be really weird. I don't know if you just like see the bones.
The teeth are just like...
The teeth are just attached
to ginormous rabbit teeth coming straight up.
I don't know.
Zero. It's like not even Latin. Like I'm trying... Because you often like... It's like Latin based.
Yeah. Haha, Maddie.
Oh, I'm so confused.
The environment of the mouth. Well, that's just like the environment. Bad breath? Is it a fancy word for bad breath?
Is it the salivary glands don't produce saliva?
I'm going to give that to you. It's dry mouth.
Oh, nice.
Oh.
Yeah.
Okay, cool.
Nice.
What, as in like if you take certain medications and things like that?
I know, it's just some people actually have
there are some autoimmune conditions where you don't produce, like they impact the salivary glands in the mouth and you can get a dry mouth.
Right. Interesting.
Xerostomia.
Love that. Awesome.
Nice new term. Next time I'm like,
Beautiful.
Yeah, like, oh, they've got it.
I've got a cold, I've woken up with a dry mouth, like, oh, this xerostomia is just killing me.
So coming back to the whole thing of like people just want to pathologize what they're feeling.
Yeah. I've got xerostomia, that's it.
Sorry, day of work. Yeah. Severe case of xerostomia.
It's really flaring up today.
Not that I'm hungover and didn't sleep enough and was snoring.
I sleep with my mouth open.
Yeah. There was another one that I looked up and it was like people wake up the morning after a big night of drinking with a hangover, and the condition is similar.
No.
Yeah. I was
my
wow,
goodness.
that's wild. But there you go. Oh, cool. Well, that was good. I'm glad you guys got them because, like, last week I was just kind of like standing there with my jaw in my hands going.
What was the condition last week?
It was synesthesia, which was the sensory.
Like you see the
word
milk,
you see a word
and you
orange
taste
and you
milk.
taste orange.
Fascinating.
Yeah.
Interesting.
Which I feel like happens anyway. Like if I think about sour lollies, I will produce more saliva.
Yeah, but this one was like, I think you actually, like if you see the word orange, you start like, it's like, oh, I'm eating an orange, but I'm not actually eating an orange.
It's obviously what, like, we taste actually in our brain and it's how it receives and, the information.
The chords are twisted.
Yeah, or like it's, the information processing between vision versus taste is getting confused and somehow it's activating the taste part of the neurons rather than the vision part of the brain. Fascinating.
See, that's what freaks me out. I actually don't have a sense of smell. I've had it investigated. It's still ongoing. But people are like, how do you taste? Because most of the taste, like it's all interconnected. Like as far as I'm concerned, I'm tasting food. Maybe I'm missing out on like a whole world of taste that I don't know about.
She'll never know.
Yeah, it's weird. It's very, very weird.
There you go.
Alrighty. So you did mention earlier about your experience working with people living with polycystic ovarian
syndrome?
Yeah, PCOS. I would just say it's PCOS.
PCOS, easier.
Yes.
And to be honest, PCOS is a stupid term because they don't actually have cysts. They have follicles. Mm-hmm. And there's this confusion that people with pelvic pain have PCOS because they've got a big follicle. PCOS, you do not have big follicles. That's completely different. PCOS is a condition of multiple follicles and the reproductive cycle not happening appropriately. So you can't say polycystic ovarian syndrome doesn't matter because it's a crappy term. It should be called maybe ovarian hyperandrogen dysfunction, but that also doesn't really roll off the tongue. But it's a crap name for the condition because it gets everyone confused.
Yeah, right. Okay, well, that's really good to know. And look, as someone who actually has had investigations around that as well myself, I feel like I'm just learning off you as well from my own personal experience.
That's the whole point of the podcast. So that is good.
But could you dive in a little bit more about, when it does come to, I'm just going to say PCOS, who's in charge of managing that? Like, what does management sort of look like, and what are some other considerations that anyone listening might need to know?
So just a brief summary on PCOS. It's a condition that is got one name, but it's actually incredibly broad, the phenotype. So phenotype is how the condition presents. Mm-hmm. It's generally, rather than the ovary picking one follicle, which is a kind of immature egg, to be ovulated each month, lots of follicles develop and they kind of get into this arrested development state that there's lots of follicles developing, hence the name polycystic ovarian syndrome. Should be called polyfollicular ovarian syndrome. Because there's so many follicles developing, they make more hormones than normal. Mm-hmm. And the balance of the hormones from the brain, the LH and the FSH, and insulin resistance means that more testosterone is made, because all of our estrogen actually is come from like immature testosterone first. It's metabolized to something called androstenedione, which then becomes estrogen. But because of the environment with the ovaries, that androstenedione becomes more testosterone. So people aren't ovulating. They have higher androgen, so male hormones that can cause acne, increase hair growth, and it's often associated with insulin resistance. And insulin resistance is a combination of genetics and lifestyle. And with polycystic ovarian syndrome, it can be very mild versus, very severe. And so you can't put everyone in the same brushstroke.
Yep.
Depending on the symptoms of the condition and what's bothering the person will be what the treatment is. If it's a 25-year-old with bad acne and body hair, she's not worried about fertility, you'll focus on the androgens. You might put someone on the pill because that does lower the androgens and also protects the endometrium, because if you're making estrogen and testosterone, it will cause growth of the endometrium. Mm-hmm. But if you're not ovulating, you don't get the progesterone that then thins that lining. So if you have PCOS and you're not ovulating and you're not given either some type of progesterone through the Mirena, through the pill, the cyclical progesterone, you can get endometrial cancer. I've had patients younger than me who've had to have a hysterectomy from untreated polycystic ovarian syndrome, and, in part because everyone is so scared of going on the pill. The pill could be an entire podcast topic. There are issues with how the pill is prescribed. It's not spoken about enough, but it does have a very important role in managing some medical conditions. That's another topic. But so it could be managing the androgens, the endometrial protection. If someone's wanting to fall pregnant, they're not ovulating. That's a different thing. We're not going to put someone on the pill. And of course, this is with lifestyle, healthy diet, looking at the guidelines. Mediterranean diet is what's recommended, and just the standard exercise, 150 to 300 minutes of moderate to vigorous physical activity per week. Then if someone's wanting to fall pregnant, that's another consideration. We do know people with PCOS have high rates of developing type 2 diabetes, metabolic syndrome. So if they're older, they've had their children, I'm really focusing on what's your cholesterol, what's your triglycerides, what's your waist measurement, and trying to look after that metabolic health. In terms of PCOS, you can also have almost crossover with what we call functional hypothalamic amenorrhea, so losing your periods from overtraining. And that's why an individual approach is so important. If someone can have PCOS and then they lose weight and exercise more, they go into functional hypothalamic amenorrhea. So I'm not going to tell that person to, lose weight or exercise if they're lean. They don't need to.
Yeah.
And that's it. I just get so stressed and upset sometimes when I hear people who are lean and exercise lots and they're told you need to lose weight and exercise more. No, they don't.
Yeah.
It's, not what they need. They're just going to lose their periods completely.
It's raising a lot of alarm bells.
Yeah, and and we know athletes, especially team sport athletes, have high rates of PCOS. So that's why individual approach, looking at what the individual needs of the patient are rather than broad generalizations. Mm-hmm. The role of the endocrinologist, I generally think endocrinologists should manage PCOS unless the person is specifically having fertility issues and wanting to conceive. Mm-hmm. There are other associations with PCOS, very commonly associated with thyroid dysfunction, so mild hypothyroidism. Mm-hmm. fascinatingly, we see when we put someone on metformin, it actually improves their thyroid function. And it's kind of complex bit of chicken or egg, but there are, the role of insulin resistance, abnormal pituitary hormones.
Yep.
They also have increased risk of diabetes, metabolic syndrome, and that's where the endocrinologist really plays an important role.
Yep.
But you might refer to the gynecologist for a Mirena insertion.
Yep.
And again, if there's fertility. So it will depend on the individual, but I generally say unless you're trying to conceive, I think an endocrinologist should manage it. Maybe I'm biased.
Yeah, but it's very interesting though, because again, like a lot of the time people living with that condition in an outpatient setting will go to a gyno first and foremost.
Yeah, and I think often, again, sometimes I think gyno, from my experience, which we're always biased from the bad stories because they're the ones that come to us.
Yeah.
Sometimes I've seen functional hypothalamic amenorrhea incorrectly diagnosed as PCOS purely due to the findings on the ultrasound. Really important to know. And they've actually changed the diagnostic criteria recently. Having polycystic or polyfollicular ovaries does not mean you have polycystic ovarian syndrome. It's very common, especially in women below the age of 20.
Yep.
So you might have a pelvic ultrasound because you missed your period and they see these polyfollicular ovaries. That doesn't mean you've got polycystic ovarian syndrome.
Yep.
You need all the other things excluded. Polycystic ovarian syndrome is a diagnosis of exclusion. And just having that appearance on ultrasound doesn't mean you've got PCOS.
Yeah,
And that's, again, where I see people told, I'll have someone in their medical history, they've got PCOS, and they just don't. And I can see by looking at them and doing their bloods, but they're told that they have it, and then they worry that they've got metabolic dysfunction. That can develop eating disorders. We do know people with PCOS have high rates of, depression, anxiety. Really important to have that whole biopsychosocial model that we looked at.
Yeah.
And I think that impact on mental health and healthy relationships to food, we do know there's high rates of disordered eating again in PCOS. And I think the medical industry would be partly to blame.
Yep.
Being told to go fast, 5-2, keto, no Mediterranean diet. I was at a talk a while ago. They said, why are we still doing studies on what's the best type of diet? We have so much evidence that Mediterranean type dietary pattern is the best for, cardiovascular, metabolic, cancer.
It's like an all-rounder.
We're still trying to reinvent the wheel.
Yeah.
Because it's, I guess, maybe popular money, whatever. But yes, so that was a long-winded saying of, yes, endocrinologist, but lots of other people involved if needed.
How often do you incorporate like psychology or psychiatry in your management?
So much issues with accessibility. Yeah. And that's what kind of shits me sometimes with this very soft, palatable way we discuss mental illness.
Yeah.
Is, see a psychologist if you're struggling. No one can get into a psychologist even if they've got the money.
Yeah.
And if you don't have the money, what can you do?
Yeah.
I do recommend there's Smiling Minds, which is a really good free program through the government. And I do recommend people see a psychologist if they can, financially. But there are issues with access. But if people can have and especially for eating behaviours as well, if there's a psychologist who has, binge eating is really common because people are put on restrictive diets and trying to develop healthy relationships to food and exercise, which I might not have the skills or the time to do with my patient. I think we should all see a psychologist.
I was about to say, sometimes I feel like I need to just like sit in and unload, just
totally.
let it all go, let it out.
It's harder to fix what's broken. I think it's always good just to check in and offload.
Preventative. I've had the same psych on and off for, 7 years, and it's definitely helped me get to, where I am today.
Yep.
But, I wish psychology was more accessible. I think we need to change our model of mental health care because unfortunately the current model is not going to meet the demand.
What are your thoughts on the digital space becoming more and more prevalent?
I think for mental health or...
Yeah, sorry, I should have clarified that. Yeah.
I definitely think we'll have a really important role due to that accessibility, whether kind of group things will be important. I was involved in a kind of mental well-being with the Melbourne University created with Pucker Up, which is a mental health foundation.
Yep.
An evidence-based program to be implemented in workplaces. Is it going to have the same role as one-on-one individual psychology? Of course it's not. But, we talked about assumed knowledge. Even basic principles regarding, it's normal to have times when your mental health is not as good without having a mental illness. Prevention, looking for warning signs, really basic principles we should all be implementing and, be educated on. And we do need to be educated on. I think there's this assumed knowledge that we know how to communicate how we're feeling or reflect and even understand how we're feeling. So I think the digital space will have a really important role for both mental and physical health conditions.
Yep.
I do have some issues with some of the femtech companies like, kin fertility and all the weight loss ones, which are just, charging people heaps to be sent Ozempic, or, kin, which charges you heaps to check your AMH and scare you about your fertility or give you a false sense of reassurance.
Yeah.
So there are issues, but I think it's an exciting space, and definitely one that I hope I will be involved in a way that,
It's positive.
and not fear-mongering and doctor shaming.
Yeah, amazing. And like even coming back to the PCOS thing with what you said around the ultrasound, it would have been like 10 years ago now, but I did myself have an ultrasound, and I think I was quite fortunate in that the person who did it explained that, and obviously I hope that you clarify whether it's this BS or not, but explain that it's not necessarily the presence of the cysts or the follicles in which you say, but more the concentration of them in a specific, I don't know, not square meter, because that's obviously not.
Yeah. It's hard to give individual but advice. But it's the ultrasound appearance, it's your blood test, it's if you've got signs, it's your menstrual cycle. It's one part of the puzzle, and that one part of the puzzle doesn't paint the whole condition.
Yeah.
We do see, and as well, things are a bit arbitrary. We say more than 20 is abnormal.
Yeah.
Does that mean 19's fine and 21's pathological?
Exactly.
If someone's got 50 ovaries in 50 follicles in one ovary, it probably is polycystic ovarian syndrome.
Yeah.
So it is. It's looking at, bigger picture rather than these very arbitrary
strict diagnoses.
Yeah.
And you mentioned earlier off air around like the lean PCOS. So if somebody isn't necessarily presenting with the high androgens, the acne, excessive hair, maybe excessive body weight, how do you go about, I guess, diagnosing that?
And it's a really good question, because sometimes it can be really difficult to differentiate between functional hypothalamic amenorrhea versus PCOS, and they can have this. We do know when people recover from functional hypothalamic amenorrhea, as their ovaries, so it's like their ovaries were turned off because they weren't, fueling well enough, they're under stress. As their ovaries wake up and start making hormones again, you do have slightly elevated androgens, and that's why having that experience working with that population group is important, that you don't go, oh, testosterone's 1.7, you've got PCOS, lose weight, let's put you back into functional hypothalamic amenorrhea.
Yeah.
For lean PCOS, we do know that they've done really fancy studies called a insulin hypoglycemic clamp, but it shows people do have mild insulin resistance with PCOS that we wouldn't normally diagnose on the standard testing, like a glucose tolerance test or a fasting glucose, but they do, 75% of lean PCOS does have mild insulin resistance. And it's the same principles of healthy diet, Mediterranean diet, exercise, having a weight neutral approach, so that you're not trying to get people to lose weight, but it's just, keeping your weight, and those same healthy principles, and treating what the actual issues are. Is it the anovulatory dysfunction? Is it the elevated androgens? If they're still ovulating, do we really need to treat it? I was at a really interesting conference, the Women in Sport Congress, saying for some of these people with PCOS, that slightly elevated androgens might be having a beneficial effect on their sport. So again, it goes back to the individual in front of you rather than, and that's the art of medicine, and that really comes with experience. And that's my concern again with the rise of scientists kind of moving into being online clinicians when they don't have that years of experience of working with patients and seeing the nuance and the complexities of the person in front of you, rather than, making extrapolative advice from data. And so the lean PCOS, we say weight neutral approach, the same healthy lifestyle advice, and looking at the actual issues. And sometimes metformin, we do know people with even lean PCOS going on a medication to improve insulin sensitivity will increase ovulatory function. And they go, but I'm lean, I don't have diabetes, why do I need to go on metformin? That's probably really mild insulin resistance, that they're already really active, they're eating well. They might need a medication, and needing medication is not a failure. I say to people, we haven't evolved perfectly. Our lifestyles have changed rapidly in the last few hundred years without biological, DNA changes. Yeah. And sometimes we do need a medication, and, we might have thyroid dysfunction and have Hashimoto's, and we've tried everything right with our diet, but you need to take thyroxine, and needing to take away as if we have complete autonomy over our health, because some things just, shit happens, some things are unlucky, and it's not a moral personal failure to rely on medications.
No, it's just an added layer of support.
Exactly.
Amazing. Well, thank you so much for explaining that. That was like very what's the word? Bit selfish. It was very beneficial for me as well.
Oh, good. Yeah. Well, and PCOS impacts 1 in 9 women, so it's very common.
That's insane.
Yeah. Yeah. So most common cause of anovulatory infertility, and it's not really talked about or known much about. So we do need to normalise discussions regarding women's health. I know today was supposed to be broad hormones. We've mainly talked about women's health, maybe because women's hormones are a little bit more complex.
Yeah.
And I think that is, especially on social media, where there's a lot of the misinformation or confusing information, and part of why I enjoy specialising in women's health.
Maybe another episode later on down the line with you then for the male hormone debrief. We'll wait and see.
The male menstrual cycle.
Yeah, apparently. Yeah. The 24-hour one.
Oh,
Well,
God.
no, thank you so much. That was a great chat. I really enjoyed it.
Yeah,
Yeah, thank you,
likewise.
Izzy.
We loved having you on today. We're so glad you made the trip out to come and meet us here at the studio. But
It's good to venture south.
yeah, there you go. Get out of the busy CBD.
My dad was a lifesaver at Wander Surf Club,
Oh,
so I'm
amazing.
getting back to my roots by coming down here.
That's great. That's such a nice surf club as well. And look, if our listeners want to learn a little bit more about you and find you, where can they do that?
Yeah, so probably I share some content on Instagram, Dr Izzy Smith. I haven't done as much in the last few months. I think I've just been a bit tired.
You've been on break recently.
Been on break, but I have a years of catalogued post on PCOS, athlete health, bone health. Maybe I'll just run out of stuff to talk about now. I'm like, I've talked about everything I need to talk about now. But you can find me on Instagram. I also work in private practice at Balmain Sports Medicine in the Inner West and at St Vincent's Clinic in the private as well. Or I often do talks, through the running company Femi I work for, and we're doing one in the Northern Beaches in Manly soon, and also one with King's Cross Run Club, just educating women about, the impact of their hormones, their menstrual cycle, and athletic training and performance and health. So
Amazing.
lots of ways.
Oh, that'd be
Hands
cool.
in a lot of jars. It's great.
Yes.
Thank you so much.
Thanks,
and I
guys.
feel like our listeners are going to get so much from this.
Fingers crossed. Thank you.
Thanks for listening to this week's podcast.
Be the first to know when the next episode drops by hitting subscribe on wherever you catch your podcasts.
And don't forget to follow us on Instagram at we don't know yet.pod.
See ya.